Welcome to the show. My name is Dr. Hassan Mallick. I'm a psychiatry trainee in Lancashire. Pleased to share that I'm going to become a higher trainee soon, and I'm going to specialize further in adult psychiatry and old age psychiatry. As you would, I asked around with my peers and colleagues who work with me, and just to see what everyone else was doing with their time and future careers. And one gentleman in particular was very, very convinced that old age psychiatry is the way to go. He, in my trust where I work, he's won the Higher Trainee of the Year twice in a row. We call those the Gosal Awards. He's also won multiple commendations or awards for teaching, as well as contributions to different fields, not only in psychology. The gentleman I referred to earlier, his name is Dr. Thomas McConnell. So I gave a little bit of an overview of just your roles and titles, but can you tell me a bit about what you do and how do you spend your time in the clinic?
Absolutely. Well, I'm absolutely delighted to join you, Hassan, and you're completely right. I am a very strong believer that psychiatry is the best medical specialty. And more than that, I'm convinced that of all of the different psychiatric subspecialties, old age psychiatry is the best of all of them. So for anybody listening to this, I really strongly encourage you to do your best at whatever you're doing. But if that thing happens to be old age psychiatry, well, I think that's the best choice you can make for me.
So can you share a bit about your journey? I know that you had quite a roundabout way, and I can totally vouch for you that you've have sampled different specialties, and then you've decided that yes, old age psychiatry is the one for you.
So I've had probably a slightly non-standard route to medicine and then to psychiatry. I initially went to university to study psychology because I had a real interest in kind of how people think about the world and how people experience the world and how people feel about the world. And when I went to university first, I was actually studying both religious studies and psychiatry. And over time, I became more interested in the more sort of scientific aspects of sort of human experience. And I drifted a bit away from religious studies. And I switched my study to full-time psychology. And then in about the second or third year of studying psychology, I decided that I felt I had more to give really to medicine as a discipline. And so I finished my degree in psychology and I applied for medical school. And I really enjoyed medical school. And as I was going through, I always really enjoyed psychiatry, but I really enjoyed surgery a lot as well. So I studied, after I did my foundation training, I did 2 years of surgery training and did all my exams, the MRCS exam. And then I got to a point where perhaps I felt that with surgery, it was really enjoyable. But ultimately, I I had a really difficult experience in my life, to be truthful, Hassan. I had a friend who became um, very unwell and then sadly died, and I was very involved in looking after him. And I realized that one thing that I really took from it was how much he valued his work, his job. He was a university lecturer, and how much he really wanted to basically get back to doing that. And it wasn't going to happen, tragically. But I realized I looked at my job and I thought, that just isn't how I feel about surgery. I really like it, but I don't really love it. I don't really feel that kind of passion and vocation for it that he did. And I kind of felt unsatisfied really with surgery after that. And I knew I probably couldn't really continue. And after a bit of searching and thinking about maybe doing general practice or maybe going into academia or maybe doing public health medicine, I decided that really I'd go back to what I had been interested in kind of from the start, which was kind of the human mind and do psychiatry, and I've been extremely happy with that. And it's a fantastic meeting point of the scientific and the cultural, psychological, lots of different elements of lots of different ways of understanding human beings and human experience, and it brought them all together for me into one discipline. And it also gave me a way of kind of helping people and doing something which was kind of hopefully valuable for people and could improve people's lives and make people more comfortable. And so I have stuck with that, and then within that I've chosen old age psychiatry.
Well, I'm sorry for your loss. Although it's kind of bittersweet that your friend did inspire you to kind of recalibrate your life and see what's really how you want to spend the time that you have here. Old age psychiatry is a huge topic. What do you have in store for us today?
Well, as you say, old age psychiatry is a huge topic, and it's such a huge topic because it's really all of sort of psychiatry for adults. Because anything that can happen to an adult can happen to somebody above the age of 65. But it also includes the need to be quite knowledgeable and expert on a group of disorders which are very unusual in people below 65, and that's mostly the sort of dementias and neurocognitive disorders. So I think it'd be really good to talk about dementia, because that's one of the things that's kind of unique really to old age psychiatry. We are, as old age psychiatrists, really the experts, I think, in diagnosing and managing dementia. And it'd be good to talk about that. It'd be good to talk about the approach we take to supporting people with dementia, both through some medications we use, but also through the broader kind of array of interventions that we have available. And possibly we could think about some of the challenges that certainly I face in my working life to do with working with people who have, and families who have somebody in the family who has behavioural and psychological symptoms in dementia, sometimes called BPSD.
So, Thomas, there's a gentleman who comes to you in your clinic and he says, or she says, that I've been more forgetful recently, and I've noticed I forget people's names, or sometimes I don't recognize their faces. I've heard about dementia, and I'm kind of scared. How would you approach this situation? What would you assess, and what would you tell them about the risks they have of actually having dementia?
And this is a very common reason to come and see an old age psychiatrist. I think before we talk too much more about how we go through the assessment, it's really important to understand the distinction between when we say dementia, what we mean, and when we say cognition, what we mean, and then when we say the disorders like Alzheimer's disease or a vascular dementia, what we mean by these all separate things and how they relate together. So I think the first thing to say is to understand what cognition is. So cognition really just describes the thinking skills and the reasoning skills and the skills we use, or our brains use, to process and manage the world and manage experience. When we talk about cognition, we think of it in several different domains. And these are quite intuitive, I think. When you think about how people deal with the world, it makes sense that it's a set of skills to generate, to come up with speech like I'm doing now, or to understand speech, which is perhaps what you're doing if you're listening to this podcast. But we also have skills that we perhaps think a bit less about, like our ability to do practical tasks. And that's a cognitive skill, or our ability to direct attention. And that's another cognitive skill, or a cognitive domain we call kind of executive functioning. And that's executive functioning in the sense of it's the ability to direct attention to certain things and keep attention on things that we need to keep attention on.
So that would mean everything from dressing yourself in the morning to, cooking a meal. So all of that would require some kind of executive decision or planning or sustained attention.
Exactly. But also sometimes we need to have divided attention. So sometimes we've got, one person saying one thing to us. We've got our little kid saying, "Daddy, daddy, daddy, I need this. I want to buy this sweet." And then we've got the shop teller saying to us, the bill is X number of pounds. And then we've got somebody behind us saying, "Oh, sorry, I've mixed up my items with your items on the conveyor belt." So that ability to keep attention in several different places and move attention between different things, that all is a cognitive domain as well. But the cognitive domain that we most commonly think of with dementia is memory, to the extent that many people really, when you say dementia, they just think of memory and a memory illness.
So memory is obviously is something which is the function of the brain. And can you talk a little bit about how memory is usually formed, and then how it breaks down kind of in dementia?
For sure. Again, with memory, I think it's fair to say that there are some different theories out there. Probably the best established cognitive theory tells us that there's a sort of series of buffers into a long-term memory store. So we have a kind of perceptual buffer. And when we say buffer, we mean a kind of short-term storage area. And then when things come into that short-term buffer, they can either be then put through to short-term memory, or they can be kind of discarded, almost forgotten. And then when they're in the short-term memory, they can either just stay there for a short period of time and then go and be forgotten, or if they're kind of rehearsed repeatedly, or they're very important, they're very salient, they can then enter a long-term memory store, and that long-term memory store then is where we retrieve memories from later on. And that's really important to understand that, because there's several different components of what go into making a memory. So the first one is we have to actually be able to attend to and pay attention to the important things happening in the environment. The second thing is that we then need to be able to get things from the short-term memory store into the long-term memory store. And then the final thing is that we need to be able to retrieve memory from the memory store back to the sort of the processing bit of the brain, remember the memory. And that can be important because sometimes people can have a deficit in different places. So, for instance, if someone's struggling to pay attention to things, they may not be able to be very good at forming new memories. And as an example of this, if you imagine you're trying to revise for an exam and you've got like music blaring and you've got kids running around, or the dog's barking, or your mum maybe is shouting at you about needing to do something, it's very difficult to pay attention and remember. But if you're sat in a very quiet, peaceful space without too much distracting you, it's much easier to get those memories in.
So, which part of this chain of events in forming memories is affected in dementia?
It can vary, and in fact, all of them to some extent can be impacted in dementia. We think that probably the process of encoding new memories is one of the earliest ones to get affected in the most common forms of dementia, and then the ability to draw back old memories is then affected a bit later. However, it can just depend a bit on what type of dementia you have.
Yeah, and I think it's not only dementia, but other things, even like you mentioned, even for example, in depression, it can be harder to make memories or to remember things as well, and mood can also affect this. Am I
This is
correct in saying that?
That's absolutely true, yeah. And in fact, it can not only do that, but it can actually impact the type of memories that we're able to make and the type of memories we're able to bring back. So when somebody's depressed, one of the things we know for depression is that people often feel quite bad. They feel quite negative about the world. And when they have that worldview, it's more difficult to remember good things that are happening, encode those good experiences into memories. And it's also more difficult to remember kind of positive memories. So it's easier to draw back and recall a bad memory when you're depressed than it is to recall a good memory. And that can be one of the challenges when we're working with people with depression, is that it can feel like, and the memories that come back to you are all kind of bad, and it's more difficult to remember good times. And that can be one of the things that when we do psychological therapies in depression, we can work on to try and help people adjust for that.
Okay, so you talked about cognitive domains and how memory is usually the one of the first things that you see in your clinic. Going back
Yes.
to our gentlemen, and they're complaining about being more forgetful or having some like not being able to recognize things. How will you assess whether it's something like what we talked about, whether it's depression or whether it's dementia? What would you ask them? Is there any test, any blood test, anything like that you would do?
I think understanding that that's what cognition is, we can then think about, and we need to be very careful to make a good diagnosis for somebody. And so we can think about what a dementia syndrome is. And when we say syndrome, we mean a condition where there are multiple different components of it, which we recognize cluster together, but for which not necessarily every single component is always present. So we know when we talk about dementia, we're talking about a loss of cognitive ability in excess of what would be expected for somebody's age. And we're talking about a situation where that happens without any other cause being able to be identified, and where the likely cause is one of the dementia illnesses. And it's really important to understand that, because as people get older, their cognitive ability changes and it can decline over time. And that's a normal part of aging. And in fact, that's going on from quite early on in your life. You're starting to lose those abilities. But when we talk about dementia, it's not just the normal loss of those abilities, it's something in excess of that. And it's in excess of that, and it's in excess of that in a way that causes you to lose the ability to do things that are important to you, that are important to your life. So, for instance, some people might be losing the ability to navigate around town. And that's important because we need to be able to do things like go to the shops or, go to a restaurant. When we talk about dementia, though, we need to think about how we're going to diagnose it. And the really two key elements of diagnosis in dementia are to take a really good history from the person, but also from, if at all possible, from a close friend, family member of the person. And that's really important because when we've got dementia, we sometimes don't realize that we're losing abilities in certain places. But it's also very important to take a good, robust history and assessment to look for any other potential causes, because we're always looking if there could be a reversible cause of this. Dementia is very difficult to treat, and we don't have any cure for dementia. But depression is a much more treatable illness. So we don't want to diagnose somebody who's got depression.
And I think about the Alzheimer's Disease International NGO or charity organization says about 75% of people with dementia are not diagnosed, which can go up to 90% in some low and middle income countries. It's kind of a staggering figure considering there's about
Huge.
50 million plus already with dementia, and the WHO says that's going to increase over the next few years, or going to show an increasing trend till 2030, where I think it's going to get closer to about 75 million. So you were talking about a good diagnosis and treat what you can. So what is a reversible cause or a treatable cause of dementia?
I'll just say one final thing, which is, so we've got the history and the clinical assessment, as we would do with all psychiatric patients. So in fact, all patients will take a good history and do a good examination. But then the second part is that we do some form of cognitive testing. And then with those two together, we sometimes do brain imaging as well. And really, ideally, we'll do brain imaging. That's partly to rule out any other cause. As you say, some of the other causes of changes in cognition can be things like structural diseases of the brain, so brain tumors, or some cases subdural hematomas. But it also, sometimes we can use that brain imaging to help us make a diagnosis of a particular type of dementia. And so if we see a loss of brain tissue in certain areas, those patterns can be characteristic of certain dementia types.
You mentioned subdural hematoma. What is that?
So subdural hematoma is a condition that happens most commonly in older, frail people, and it's more common in people who are taking blood thinners. But it's a condition where, usually following a head injury, blood starts to collect between the bone of the brain and one of the covering layers of the brain, and it slowly squashes the brain over time and can cause the brain to then sort of basically not be able to function, and so people lose cognitive ability. And that's very important because it's a completely treatable. It's something that the neurosurgeons can drain off the blood, or usually by that point it's kind of liquefied to water, a kind of watery serous fluid, and they can drain that off, and then people get better. So it's really important to make sure that you've found any reversible cause of dementia and treated it.
Vitamin deficiencies as well. Certain vitamin B12, I think, can also cause that. I'm liking our conversation today because it's testing me a bit from my exam memory as well. So you've done some brain imaging. You've taken a good history. Anything more you would have to do before you can make that call?
Well, really, no. In many cases, that's the sort of core of it. We always do a sort of baseline set of blood tests, and that's, as you say, B12, folate. Sometimes we do iron studies. If it's clinically indicated, we might think about doing HIV or syphilis, which again can be causes of cognitive changes. HIV in itself can be a cause of dementia as well, so that's quite important to identify. And in some cases, we might look for sort of conditions like Wilson's disease. And once we've done that, if we need to do brain imaging, we've done that. We usually try and do brain imaging if it's sort of safe and appropriate to do so. That is the core of the diagnosis. For certain people, we may do some additional tests. And those additional tests could be further neuroimaging, and that could be neuroimaging that looks at things like a DTA, a DAT scan, which looks at dopamine transport. And in certain types of dementia, that can be a diagnostic form of imaging for a particular type of dementia. But we might also sometimes look at more kind of complex neuropsychiatric testing. And that's where a neuropsychologist will meet with somebody and they will do a complex, an extended battery of tests that really finely characterize cognitive ability in many different domains in several different ways. And that can be helpful in equivocal cases where it's difficult to know if it's definitely a dementing syndrome or if it's not. And so we use that for a select subgroup. And a final type of really important, but sometimes forgotten, unfortunately, type of testing that we do is we can use things like an AMPS test, and this is delivered by occupational therapists who are specialists in memory assessment. And the occupational therapists are really good at looking at people's fine ability to conduct quite complex daily tasks. And I think the example of that is to think about how many different steps it would take for you to make a sandwich and a cup of tea, getting the bread out of the cupboard, getting the cheese out of the fridge, getting the milk out of the fridge, filling the kettle with water, putting the kettle on the boil. And so those tests can be really helpful in just picking out in those kind of borderline cases, is this dementia or is this not? Where exactly is the functional level for this person?
You've done all these tests on that gentleman, and you, let's say that unfortunately they do have this diagnosis. The patient wants to know why them in particular. Is there something about certain individuals which makes them more likely to have dementia? Are there risk factors to it?
There are absolutely risk factors, and I think this is a very common question for people. Why has this happened to me, or why has this happened to my loved one? And it's very important, I think, that we remember that nobody is ever to blame for developing these conditions. They are just devastating, extremely unfortunate things to happen to people. And although that there are modifiable risk factors, it's very important never to let people feel like they're to blame for what's happened. The key risk factor though is age, and that dementia just gets more common as you get older, to the extent that really by the time you're in your ninth decade, your 90s, you're getting into the point where almost 35 to 50% of the population will have dementia by the time they're coming to the end of their 90s at least. Global estimates of that vary, I think it's important to say, but nonetheless, age is the biggest risk factor. There are some non-modifiable things, by which I mean things that you couldn't change, and they are your genetics. And we know there are certain genes which are associated with people who have a very strong family preponderance, very strong inherited type of dementia. But there are also genetics which just increase the risk of it. This is things like APOE4. Other things that we can't change are our ethnicity. And if we have a condition or if we are somebody who has Down syndrome, we obviously can't change that, but it does can increase risk, or it does increase risk for somebody with Down syndrome. There are modifiable risk factors, and these are really important, I think, to communicate to people who are at high risk of developing dementia. It's really important to communicate to everybody, though, because they're things that we can all change. And those tend to be things like diabetes, central obesity in middle age, consuming alcohol, and certainly consuming alcohol above what the sort of safe limits are considered, or the relatively safe limits are considered by the government as published at the moment. And I think 14 units of alcohol a week, smoking, and all of these head injuries, all of these things are risk factors for developing dementia. So I think the first thing to do is that we need to give people a good quality diagnosis. And so we've done our assessment, we've come up with a robust understanding, we're confident we're not missing a treatable disorder, we can identify that this is a dementia syndrome, and we can identify the disease that we think is causing it, be that an Alzheimer's disease or a vascular disease or some other form of disease which causes dementia. And I think that's really important because that makes a difference to how we support people best. And it also makes a difference to prognosis, or the length of time people can hope to have particular abilities to do things and when somebody will eventually die. I think the really key thing when you explain these things is to recognize that it causes a huge amount of fear, understandably, for people when they're coming to you with these. And it's very important, I think, to go through carefully and slowly, but also make sure we do good things like write to people after the diagnosis with their clinic letter. And in our practice locally, we have a follow-up service, and that certainly should be something that most memory clinics do. And that after a diagnosis has been given, you see a memory specialist nurse, and they have time to go through that with you, because it's such an overwhelming thing for people sometimes to hear, and can be a piece of absolutely devastating news for people. But when that has been delivered, it's really important to think about the person themselves, what their priorities are, how they feel about the different types of things that we can do. There is no robust cure for dementia at this time. Having said that, there is things on the horizon like aducanumab, which is just approved in the USA for use, which may be a treatment for dementia, and certainly they're likely to come in the future. But at this time in the UK, we don't have access to that, and it certainly is something which is a lot of debate about whether it's really truly effective.
So I know that we have a couple of treatments or a couple of medications to slow down the progression or the decline, but like you said, it's not curative. We can't stop the breakdown or the neurodegeneration of the brain itself. Is that it? Is medicine the only option we have for support?
So it's not by any stretch of the imagination. And I think one of the things that's really important to understand with dementia, and in fact, why I really take a lot of value from working in the field with dementia, because there's always something that we can do for people. So often that can be things to do with medication that can help to retain cognition, retain ability and function for a period of time, or at least slow down the loss of that. But even aside from that medication treatment, there are things that we can do at every stage of dementia up until the point where somebody is at the end of their life, where we can always do things which are going to improve people's function, improve the meaningfulness and value that they experience in their life and that their carers have, and improve the kind of experience of for them. The key things we tend to look at would be, in the early stages, we try and very much encourage people to try and reduce the risk factors that they have. So this would be, as we've said before, things like trying to deal with obesity, consumption of alcohol and so on. So look at diet, look at exercise, smoking, alcohol consumption. But we also have options like psychological interventions, and this can be reminiscence therapy and narrative therapies. And that can be really helpful for helping people to, remember things that are important to them and find ways of doing it. We can sometimes look at kind of tricks and tips to help people get by in the world, compensate for some of the loss of cognition that they're experiencing. And we can use things like optimizing an environment for somebody. And this gets really important as dementia becomes moderate and then severe, to help reducing boredom or isolation that people can sometimes encounter when they have dementia. And then finally, really important, that we support people's caregivers, and that can be through third sector organisations or charitable organisations that support people. It can be through respite for carers. It can be through financial assistance. And all of those things are really important to kind of support the person and see them not just as the patient themselves, but see that person in the broader family and social networks that support them. So if we can get that right, we can often get much better outcomes for people. Having said all of that, we do use memory drugs, and they are helpful for a group, a proportion of patients, although not everybody. The memory drugs are really primarily developed and used for Alzheimer's types of dementia, and they are acetylcholinesterase inhibitors and memantine. And these help to improve and stabilize cognition. They can improve cognition for a small group of people, and they stabilize cognition for a large group, and they slow the decline for another group of people. So they're valuable, but they can have side effects. And so it's always a balance for the individual.
In this narrative, does the individual themselves, do they have insights? Are they aware of the decline of their memory and that things are not what they seem? Is their insight preserved?
That varies, I think, for every individual. And certainly some people in particularly the early stages can be quite aware and quite anxious because they realize that they're forgetting things or that they're having other cognitive difficulties. But as the disorder progresses, as the dementia progresses, usually people will lose insight and they'll not realize that they're unwell.
Okay, and I also read a little bit about some alternative therapies like music therapy, aromatherapy. Is that used here in the UK?
So yes, although I think it probably varies a lot by different areas. It really probably relies on having somebody in that area who has the skills to deliver those interventions. The evidence for them is reasonable, but I think it's one of those things where I guess most kind of specialists would say the negative effects of it are likely to be very limited when it's delivered properly. And so even though the evidence basis for it is somewhat, it lacks some definition, it's probably worth considering for people.
So there is the actual disease itself, let's say the breakdown of the brain, and we talked about genes and their effect and risk factors as well. You mentioned PTSD in the beginning. Well, can you talk about that and how you treat, or what is that? What are the, what should I say, auxiliary or concurrent other problems that go along hand in hand with dementia as well?
Sure. So BPSD stands for Behavioral and Psychological Symptoms in Dementia, and it describes the range of different experiences that people have as the dementia syndrome goes on, progresses, that cause difficulty and distress for them or other people. And it's very, very common. In fact, almost everybody with dementia will have some form of BPSD at some point. So it's very important that we understand how the best way to approach it is. So it's really important to think of people holistically and think of all the different things that can go, into making somebody struggle or feel unsettled. And we can think about that in terms of physically. So is somebody feeling physically unwell because they've got an infection, like a urine infection or a dental infection or an ear infection? So when I'm asked to assess somebody with BPSD, one of the things that I might be talking to their family about would be to say, are there particular times that you're, this person is getting distressed or upset or having these experiences? And if they say, oh, it's particularly meal times, that might make me think, well, are their teeth sore? Are they getting pain from a dental infection? Or if somebody's pulling at their ear, does that suggest that they might have an ear infection? Or if it's, they're seeming upset when they pass urine or they're passing a lot of urine, does that suggest a urine infection? We then also might think about very common things, so things like constipation. And, I don't want to, make anybody feel uncomfortable if they're eating their dinner while they're listening to this. But, if you've ever felt really bunged up and like you haven't moved your bowels for a period of time and you feel really uncomfortable with it, it can be difficult. If somebody's asking you to do something else and pay attention to things and you're feeling really uncomfortable, people without dementia can struggle a bit. So for somebody who's got dementia and struggles to make sense of all the different things that are happening for them that they're feeling and sensing, that can be a big challenge. And obviously that's very treatable with laxatives and so on.
Yeah, I think one thing to kind of reiterate is that because communication deteriorates with time as well, so not only voicing your own needs as well as understanding communication, so both of them deteriorate. So then it sounds a bit like detective work where the patient themselves cannot, unfortunately, communicate what the problem is with them and what they need help with.
Absolutely. I think the other things that we tend to think about are, could there be, mental experiences for this person that are unpleasant, uncomfortable? So for instance, are people feeling bored? Are people feeling lonely? And although it's upsetting to think about, it's very important that we always remember the possibility of elder abuse and neglect, because that can sometimes present with these BPSD symptoms. And so we always need to keep that in our mind. Is there a safeguarding angle to what we're doing here? Is there a risk that this person could be being not treated well, treated badly?
Just quickly, as we're nearing the end of this segment, what are the risks, if any, to other people? How bad does the deterioration get?
So certainly, when we think about risks in dementia, it's really important to think about the risks that that person might pose to themselves, the risk that person might pose to other people, and the vulnerabilities for that person. And certainly, risks to other people can be if someone's very aggressive or sexually disinhibited. That's very important to understand that. And it's very important to understand that people can feel terrible about putting their hand up and saying, look, I don't feel safe with my husband or wife anymore. And that can be really important to support people at that time and recognize how upsetting it can be that somebody who's been your partner for many, many years is now, at a point where you can't really safely look after them at home because you're at risk or they're at risk to themselves.
And how would you treat that if someone's becoming, let's say, aggressive? Is there a role for, usually, for example, in younger age groups, we, if someone has aggression or impulsivity, we use things like antipsychotics?
So the key element of this, I think, is to try and work out as well as possible, get as good an understanding as possible as to what's causing what you're seeing and what the person is struggling with or those around them are struggling with. Because once you understand what the underlying driver of that is, you're in the best place to try and treat that and reduce that risk, reduce that difficulty. However, we do use psychotropic medication. So we sometimes use things like sedating medication, like benzodiazepines. We do use antipsychotic medication. I think the really important thing to say is that we use it as infrequently and at the lowest dose and for the shortest period of time as is possible. And the reason for that is that it is associated with a significantly increased risk of death, morbidity, and it's really important to understand that. So it is used and it can be necessary in some people, but the benefits of it have probably been less. We recognize now that the benefits of it are probably less than they'd seemed to be from research in the past, and that it's something which really we would only look to use where there was no other option. Everything else had kind of been tried, and the risks were such that we felt that the risks of using this medication were less than the risks of not using this medication.
I'm kind of happy to hear that you seem not to treat medications or let's say drugs as the first line, and you always seem to, whenever I ask you about management, you always seem to come back to what does this person need and how can I kind of avoid using something which might end up causing more harm than good, or which should be used as a last resort, like you said?
I think that's very true, and I think one of the things that, again, talking about psychiatry as a profession, is so satisfying about working in mental health, and it's particularly satisfying working as a psychiatrist for older adults, is that we have this opportunity to understand the person holistically, and it's an enormously powerful frame to have on human experience to just put the picture together as best we can. And I sometimes think it's a bit like having different lenses, and maybe in other aspects of life we tend to use one particular lens. We use a psychological lens, or we use a biomedical lens, or we use a social lens. But in psychiatry, we can use all of those lenses to understand different things in different ways. And if one lens isn't helping us, if the social or the psychological lens isn't helping us, the biomedical lens may help us to bring something into focus and understand and find a way forward with things. And so I personally find that one of the most satisfying elements of my job is that I can deploy these different kind of ways of understanding human beings and human experience, for the benefit of my patients to kind of make sense of what's going on.
So we're nearing the end of our time for the show. I thought maybe we can continue and talk about carers and caring for dementia and what kind of challenges that has. And I'm talking about the emotional toll that it takes. How can you tell me about your experiences about carers and any stories you'd like to share?
So I think people who care for those with dementia take on one of the most challenging things that you could do in life. And that is more challenging, perhaps, if you are somebody who is emotionally or personally very close to that person who's got the dementia. In the early stages, I think it's important to say that many people can, function relatively independently with perhaps small levels of support, just to kind of make sure certain aspects that they're struggling with in their lives or they find challenging, that their needs are met in those areas. And we hope, and we're always aiming to maintain that period as long as possible. However, as the disease progresses, people do lose the ability to do things, and certainly as a more moderate type of dementia is there, people are likely to be struggling to stay orientated to time and place and what's going on. They may be starting to struggle with kind of key parts of their daily life, dressing, washing, and so on, or elements of it, if not all of those activities. And then as dementia becomes more severe, obviously they become fully dependent on others for all elements of their care. I think one of the things that can be really distressing, sadly, in dementia is that people lose the memories of, and they lose the sense of who they were as a person, and they can do things which would be very out of character for them when they were well. And this includes things like somebody can forget who a wife was, or forget who a husband was, or forget who their children were, or even start referring to a second wife or second husband by the name of their first wife or first husband, which can obviously be really distressing. People can also, as we've talked about BPSD, start to struggle with aggression or inappropriate sexual behaviour, where perhaps that person had never really been like that as a person through their life. And that can be really upsetting to see somebody who you've had this close, intimate relationship with sort of start to behave in ways that are really upsetting. The reason I think it's so important is that there's an enormous burden of care, just looking after somebody, making sure they're safe, making sure they've got food and their water, and they're looked after, that they're able to attend to their hygiene, they're able to do things which they find interesting and enjoyable. And that's aside from just the emotional burden of seeing this person lose those memories, lose those abilities, lose the person that they were to this terrible disease. We can do a lot, though, to support people, and I think so third sector organisations do an enormous amount of incredibly valuable work with people, things like groups like Alzheimer's UK, and that provides enormous support to carers and people suffering dementia. It's really important, though, that from an old age psychiatry point of view, we think about the needs of those carers And that can be through supporting things like respite. And respite refers to the person with dementia having additional carers or going into a nursing home perhaps for 1 week or 2 week period of time. And that just gives everybody a break, and it allows some time for people to kind of recharge their batteries a little bit. But it can also be about having those conversations with people where we honestly talk about what somebody's needs are, and we think about where those needs are going to be best met. And for many people, as the dementia syndrome progresses, that may be a nursing home environment that's needed to properly look after them and make sure they're safe. And that can be very distressing, because it can feel for people, I think, that they're somehow not doing right, that they're allowing this person to go into another place, and that exploring that is, and making good decisions around that, is a really important part of working as an old age psychiatrist, and supporting people in making those decisions, supporting carers. I think the positive thing to say in all of this, though, is that there is a huge amount that we can do to support carers. First of all, by recognising the enormous burden they have to bear, but also making sure that we support them, and making sure that we provide the access to the kinds of support that are going to help them do that. And I think the final thing I would just say is to recognise that the people who work in managed care environments, residential homes, nursing homes, elderly mentally infirm EMI homes, and specialist wards, deploy an enormous amount of skill and human and emotional skill in working with people with dementia, and sometimes people with dementia who can be very difficult, can be very challenging to work with, or are presenting with things that are really a difficult thing to go into work and work with, and they do an incredible job in the main, and are probably undervalued by society, and I think that's a great tragedy, because it's such an incredibly valuable thing to look after our elders in general, to look after older people and people as they go into the later parts of their life, but also to look after people with dementia. And so I think that's a really important part of it, and it's something that really important that we also recognise the enormous contribution of people who work in that sector and look after people.
Right. Thank you so much for that, Thomas. I know that asking an old age psychiatrist, or specifically even something as broad as dementia, and trying to condense that into about an hour, that's difficult job. But thanks so much for sharing your time today and sharing your expertise as well.
It's been my very great pleasure, Hassan, and good luck with your new rotation. I'm so sorry that we haven't kept you in Lancashire, but maybe you'll come back, eh?
Yes, never say never. Just for the listeners as well. So as Thomas just said, I'm also shifting cities and going to the big smoke now for some higher training, and this will be our season finale, and we'll be back in November with our new season. See you soon.